and a flagship program of Triple E. I am very happy that today all our guests have joined and all our office bearers have joined in large numbers. So with this, I'm very happy to welcome on behalf of organizing team. So with this, I hand over my mic to Dr. Yogesh Parikh, Honorary Secretary General of our National IAP, to propose for welcome address, sir. Over
Yeah.
to Yogesh.
Good afternoon, sir. Thank you, Singarvelu, sir. Uh, Good afternoon and welcome, warm welcome to the everyone, all the on this all digital platform of the Indian Academy of Pediatrics. We have a triple E program, education by the essence of the experience and the bridging the expertise and the experience in excellence in the pediatric practice. So today we have our ever smiling President Dr. Vasant Kalatkarji, the President-elect Dr. Neelam Mohan Madam, our beloved President Dr. Jeev Basaraj, my dear friend Dr. Atanu Bhadraji, and two our mentors and the leaders of the APA countries and the IPA, Dr. Santosh Son sir and Dr. Uh, Professor Dr. Zulfikar Ismail sir, here as a chief guest from the Secretary General of the APA country. And our own Dr. Vijay Avle sir, Dr. Ramesh Bajania, and all the office bearer, Dr. Parmanand as a mentor from the institute and the presenters. All warm welcome to the everyone, and I welcome our President Dr. Vasant Kalarkar for the opening remarks.
Yeah.
Thank you, Yogesh sir, for your welcome. Now, I request our president, whose vision of this new flagship program of Triple E has conceived and it has went on very well during this second program. I request our president to address.
Good afternoon, all. My dear colleagues, our National President-elect, Dr. Neelam Mohan, our past President, Dr. Basavaraja, and today's expert, Dr. Santosh Son, my all Vice President, Treasurer, Dr. Atanu Bhadra, and all office bearers and executive board members, dear colleagues, members of the IP and esteemed guests, and especially I want to mention my friend, Professor Dr. Zulfikar Ismail. I bring greetings from IP, a vibrant academic organization of 47,000 members, second world largest organization. Really, I am proud to be a president of a such vibrant and esteemed organization. First, I would start by things to, I can't resist to say thanks to Professor Dr. Julkipil Ismail, to whom I met first time in Philippines, and I saw his aura, his smile, and his acuity in the program. On face, he looks like a very serious person, but from his heart, what is his administration? That's really, you could observe it in our conference at Philippines. Really, that's why people, all our members want to him as continue as a secretary, and I know more and many more feathers in his cap will be there in future. Dr. Julpikil, really, from bottom of my heart and from all 47,000 pediatricians, I really thank you for joining. Just 3 days before, I asked you that you had to be as a chief guest for our this different type of program, that is the Triple E. And without saying no, I know you had some meeting, you had some program, and that you said, this is for our academic organization. I will say yes. Really, thank you once again, and hope in future also you will have a same cooperation with us. What to tell about Dr. Santosh? He's always yes on one say. Santosh, though his intensity is but so many people feel that he's a true friend and true mentor for everybody like me. So good day and a very warm welcome to all of you. Wishing you all a very happy and prosperous new year on the second eve of this triple E. Today is special as we are having a second triple E, that is the education by essence of experience, an initiative that embodies what the IAP truly stands for, learning from one another to improve child health. Triple E is not just another program, it's a platform to share the knowledge and wisdom we have gathered over the year. As a pediatrician, our experiences shape how we care for children and mentor the next generation. Through this initiative, we aim to learn together by discussing real life cases and practical lessons, support growth by guiding and inspiring younger members to think creatively and critically, work as a team by fostering collaboration across regions, specialties, and generations. Experience is a powerful teacher, you all know, and by sharing what we have learned, we can inspire and equip future pediatricians to provide the best possible care. I would like to extend my heartfelt thanks to our office bearer 2024 and 2025, starting with G.V. Basavaraja, our immediate past president, Dr. Neelam Mohan, our president-elect for 25, our dynamic Honorary Secretary General Dr. Yogesh Parekh, and our National Treasurer Dr. Atanu Bhadra, along with my Vice President, Executive Board member, and all our experts. Your support and encouragement drive the success of initiatives like this. Really, how can I forget Dr. Singarvelu, Dr. Thangavelu, and Team Triple E who had make this program made their day and night they have spared. So really, I want to thank you, Dr. Singarvelu, Dr. Thangavelu, and my whole team. And today's our performer, that's Dr. Parmanand, who is our additional joint secretary also, and he is presenting case with his students. Thank you, Dr. Parmanand. As we launch Triple E, I invite all you to contribute, share your stories, mentor others, and participate in the learning opportunity is offered. Together, we can make Triple E a platform that transports how we teach, learn, and grow as a community. This new year marks a fresh start, and with your involvement, I am confident that Triple E will be remarkable success. Let's make this initiative a proud achievement for IIP and a meaningful gift to future pediatricians. Thank you for your dedication and for joining us in celebrating this milestone. Here is to your filled with learning, growth, and positive impact so that we can achieve our goal to serve children, community, and our colleagues with warm regard. And once again, thank you everyone. I say Jai Hind, Jai IPA. Thank you.
Thank you, President Sir. Your flagship program, which you have very clearly explained, you want to make our 49,000 members to know about what are the experienced people can educate. This is what your vision, which is being done. Thank you, sir. With this, I request our President-elect, Lady Star, Professor Neelam Madam, please, over to you, ma'am, for a few words.
Respected Dr. Vasant Kalatkar, our President, and also what a delight to see Zulfikli smile on the screen in a beautiful pink shirt. Goes to say that he absolutely encourages young girls with that shirt in pink. And also all the seniors on the dais and off the dais. It is indeed a very excellent thought of our IAP action plan by the president, where the education is being done in a way that we are able to, in fact, what's education? Well, it's in a powerful tool for transformation. If you want to bring about a change in the health, the only way you can do is through impactful, meaningful changes in the government level or change the attitude of the pediatricians in the management of children. So even education, they say, is a very powerful tool where we can bring about change in the health. So through this education, we are going to get valuable knowledge, practical insights, and guidance from the experts, because learning through meaningful discussion and collaboration across, like with Zulfikar have a big year. In fact, it's Zulkifli. Sorry for the apologies for that. And I know him from a lot of other ways. We met each other earlier too. I wonder you remember, because I've been in that. But what is very interesting about knowing him is how one can expand the spectrum. Not only being the president of the Malaysian Foundation, it's intriguing to see his spread it over through APA and IPA, but his interest is something what interested me is the rotavirus. So he was there in a member committee into the rota, into the dengue, into pneumococcal, and I totally enjoyed the video which your students made for you when you got the Lifetime Achievement Award in Malaysia. It teaches a lot of things. And thank you all for joining in this insightful program by our president and Dr. Singravelu, who is campaigning. So I am too excited to get started into this program where everyone stay engaged, stay curious, ask questions, and let's rock with the education program. Over to Dr. Singravelu.
Thank you, ma'am, for your nice words. Now it's time to hear a very dynamic president who made the year 2024 all over to the nation and internationally, none other than our immediate past president, Professor Dr. Basavaraja sir. Over to you for your words, sir.
Thank you very much, Professor Singaruvelu. Respected our National President of Indian Academy of Pediatrics, Dr. Vasant Kalatkar, President-elect Professor Neelam Mohan, Madam, and of course, our mentor was been there for Secretary General APA, Dr. Julius Ismail, sir, and Lulu Madam, and all others who has been joined, and our Honorary Secretary General, Professor Yogesh Parikh, Atanu Badda, and all the OB member, EB member. This is one of the flagship program of Indian Academy of Pediatrics. It is started on day one with an inauguration by none other than our APA President, Dr. Jocelyn Madam. And the second program, which is going to be presented by our Julpiki Ismail sir and I'm sure this is a program which is very creative and innovative, and lot of feedback which has been in the last program. And Professor Singaruvelu sir will make it more under the guidance of Dr. Tangavelu sir, because adult learning is something which is a unique, which has been benchmark of Indian Academy of Pediatrics to come out with different ideas at every year. And very thankful to our President, Dr. Vasant Kalatkar, who is coming out with another innovative program, which is then learning by experience. This is something which is the need of the hour. I am sure this program will make a big difference. Once again, thank you so much, Dr. Julpiki Ismail, sir, for joining on this occasion, our Honorary Secretary General.
Thank you, Professor Basaraj sir, for mentioning that this program was inaugurated by our APA president, now going to get inaugurated by the Secretary General of APA. So with this, now our guest, our expert, Santosh Zone sir, known to everybody. But still, as a formal introduction, I request our Vice President, Senior Most Vice President of 2025 West Zone, Dr. Ramesh Bajania sir, for your comments and to introduce our expert, our past president, Dr. Santosh Zone sir. Over to Ramesh Bajania.
Respected dignitaries of the dais, on the dais. As sir said correctly, Santosh sir hardly needs introduction, but still, he is a member standing committee International Pediatric Association 2023-25. He is a national president 2018 IEP. He is a chairperson Scientific Committee IPA Congress 2023. He is a founder national president of the Organized Medicine Academic Guild of India. He is a national president IIP Intensive Care Chapter 2013. founder president IIP Pediatric Intensive Care Chapter Karnataka. He's a founder chairman Indian Society of Critical Care Medicine Canara branch. He's a founder chairperson IIP Medical Education Chapter. Standing committee member Asia Pacific Pediatric Association 19 to 2021. As you know, he has authored 5 books and many publications, and a recipient of Outstanding Asia Pacific Pediatrician Award in 2018. His name is synonymous with intensive care in India. And right now, he's the Chief of Pediatric Intensive Care and Neonatology at AJ Institute of Medical Science and Research at Bangalore. Thank you. We welcome, sir, as a president of this function. We welcome Santosh, sir.
Thank you. Thank you,
Yeah.
Ramesh ji. Along with that, it is only a brief biodata I have given. If we start, then the entire time will be lost talking about our Santosh on. But only
It would
thing
be a
to
chapter.
the knowledge of chief guest, he is the person who brought epidemics in academics during his presidential period, sir, which is being continuously followed by all president. With this, over to Professor Santosh, sir.
Respected President Dr. Vasant Kalladkar, my good friend, the President-elect, our beautiful lady, Dr. Neelam, then my mentee, Dr. Basvaraj, and my good old friend, Dr. Ismaili Datuk, our secretary of APA, who's been there for quite some time, the strength pillar of APA, I would say. This thing is welcome to our Indian Academy of Pediatric this thing, and also Singaravelu and Ramesh for giving such a nice introduction with me. When I was a student, I think our professors used to tell us that the eyes, what eyes cannot see, what the mind does not know. I think this education by essence of experience is something similar to that, because there are innumerable, all of us have gone through that when we thought we had the diagnosis was there, but somehow it never was the same and something new thing has come. That experience will get you the next time when you see the similar cases. There, I can give you multiple example, but one of the things, like a child who had with a severe abdominal pain, and child was breathless and all that. We did the examination, nothing was there. We did a chest x-ray, nothing was there. Then my senior who was there, this was during my postgraduate time, he came and said, have you checked the blood sugar? Blood sugar was 600 plus. That child was a diabetic ketoacidosis with presenting with acute abdominal pain. Many a times they have done a appendicectomy for these kind of this thing, because this will come only with experience. That is the education which you had, that experience, what did you see, and similar things. Same thing when I was abroad. So there was on the TV that about this was in 1990s, early 90s, because that's a time when this Kawasaki disease was just getting on to the thing, and there was a even in the UK that it came on the TVs also, where they said the dermatologist, the child babies came with the infants came with the rash, and they treated like some exanthematous this thing. If they treated and the children died, and they did an autopsy, and autopsy showed a coronary arteritis. Similar way, what had happened was when I had seen couple of cases there. Then I came there, people who had not seen that, I could sort of diagnose that thing, because you've seen it, and you can correlate that those things onto your clinical practice and teach the thing. On this regard, I congratulate Dr. Kalladkar for his vision for education by the essence of experience. They are having excellent speaker in Dr. Paramanand, who's a co-intensivist in Thane, who's managing a huge load, and his students. And I think we are going to have some case scenario where it really teaches us what experience with what experience we can sort of a diagnosis this surprise diagnosis. Thank you so much for calling to me to be here, along with my good friend Datuk Dr. Zulfikar Ismail. And I hope everybody will enjoy and gain experience on this platform regarding today's presentation. Thank you so much.
Thank you, Professor Santosh, sir. You made it what our president wanted, why he started this program. You made it very clear, sir. We are very much honored by your presence, sir, and your nice words, sir. Before going to our main hero of the day, our chief guest, Professor Sulkibi Ismail, sir. But on behalf of our President Vasaj Collector, sir, I acknowledge the presence of our past President Rohit Agarwal and all other office bearers of the past and present who has joined. Thank you, sir. With this, though all of our speakers introduced very well about the chief guest, but it is our formal because our first national treasurer, who is going to tell much about our chief guest, which will inspire all of us. Over to Atanu, sir, for your remarks and the introduction of our chief guest, sir.
Thank you, Dr. Singalwelu, sir. So on behalf of the Indian Academy of Pediatrics, all the office bearers and the members, I welcome Professor Dr. Zulkifli Ismail, who is, of course, all our speakers till now had given a short introduction, and is very impressive. He is, after being a president of APPA, is now serving as the Secretary General of APPA. Thank you, sir, for putting the Asia Pacific in a world map. Asia Pacific Pediatric Association. He is a pediatric cardiologist. He is now at present in the KPJ Selangor Specialist Hospital, and is also a visiting pediatric cardiologist at the Damansara Specialist Hospital. He also heads the Malaysian Pediatric Association Journal, and of course, just like there is plenty of similarity between IAP and MPA, they have their parenting, they have their positive parenting program, and sir is in charge of this multifaceted parent education and engagement. He's a member of the Rotavirus Organization of Technical Allies also, and of course he is a member of the standing committee of the IPA. So he was a previous chairman and a current member of the Asian Strategic Alliance for Pneumococcal Disease Prevention. So from parenting to vaccines, to diseases, infectious disease, he is really, our chief guest today is really a multifaceted organization. And we are pleased and honored to have him to spend some time with IAP. And of course, we'll look forward to his precious words. Over to Singalwelu, sir. Yeah.
Thank you, Treasurer, sir, for your nice introduction of our chief guest. Definitely, he deserves all the appreciation. Sir, on behalf of 49,000 members, we welcome you to our very prestigious program of EEE of our Visionary President 2025. Now over to you, sir. We are very eager to hear you, sir.
Thank you very much, Dr. Singapore. This is it's a great pleasure. It's an honor actually for me to be here. And I think it was about 3 days ago that Dr. Vasan Kalaka called me and asked me whether I'd be free to do this. So I actually had to reschedule another meeting, which is happening at this time, so that I can be here, because I thought this was an important thing that we need to discuss. And it's also, you know, the IAP has been very active, and it's among all of the member countries of APA, looking at the webinars that you've been having and all the messages that I've got from the IAP, it is actually probably the most active national organization. And you've got, and this EEE, the education by essence of experience, is something that is very needed, because you're going to have sessions for actually young pediatricians. And it's important that you have this sort of discussion where there are young pediatricians with input from senior colleagues. And these senior colleagues will not only be sharing information, but it's more important that they share experiences, as Dr. Santosh had mentioned earlier. And this is, and that's why I thought that it's important that I actually be here. And the other thing is, I contacted Dr. Jocelyn, and she said that she did the first one, and she enjoyed it as well. So I think it's a good thing to do, and what we're going to do from now onwards is when you send a message to the Secretariat of APA, we will disseminate it to the rest of the countries, so that of all the 23 countries that are members of APA, there will be some people who will be attending. And it's our hope that actually when you have this, then the pediatric knowledge, information, and experience will be shared amongst all of us. And that will actually provide more of a balanced sort of sharing of information. And thank you very much once again for inviting me here. I was actually quite surprised that Dr. Neelam watched the video that was made by the Malaysian Pediatric Association last year. It's quite embarrassing actually, but anyway.
And also I wanted to say you got the award from your president, which I think Atanu forgot to mention. Atanu, he's also received an award from the president of his
Datuk, they call it Datuk. That's something like a Padma Bhushan, that kind of award they get.
Yeah,
thank you very much, Julpi
Thank you very much.
Ismail, sir.
Thank you.
Thank you.
Thank you so much for your nice words, sir, and making our program really internationally, because you are going to spread the message to all the countries. Means our president Vasant's vision will fulfill, sir. This is what we wanted. We are very fortunate to have you. And from your word of mouth as a Honorary Secretary General, definitely our subsequent events will go very well, and we will give in advance, sir, so that all the members of the whole world will be benefited out of this program. So,
just only. Thank you, Dr. Julkipil. Really, you want to spread. That's a basically important is the communication, that, and you are doing the really great work that what we were expecting. We were not expecting anything from you. You asked me. We were expecting that just you communicate and spread this knowledge whatsoever in India or everywhere. That's the duty of secretary. You are doing. That's why I initially told that Julkipil is a really perfect person for the post. Thank you once again, really, joining. Thank you. Honor for us.
Thank you, sir.
Thank you, President Vasant sir. As our president is very particular that this program is mainly meant for academics. So without wasting much time, we are going into the academics. And here I should acknowledge the presence of all the committee members of EEE program, who is their enormous work with this. It was made to possible. So with this, we go to the vote of thanks by our Ruchira ma'am, Joint Secretary. Madam, over to you, ma'am.
Thank you, sir. A very good evening, a very good afternoon to everyone, one and all the respected dignitaries present over here. It is my privilege to propose the vote of thanks on this special event of EEE, Education by a Sense of Experience, with the vision of bridging expertise and experience for excellence in pediatric practice. The vision of our president, Dr. Vasant Khalatkar sir. Also, I would like to thank our past president, Dr. G.B. Basavaraja sir, and the president-elect, Dr. Neelam Mohan madam, along with our dynamic secretary, Dr. Basavaraj, Dr. Yogesh Parik sir, and the national treasurer, Dr. Atanu Badra sir, for definitely giving support with our president to coming up with this very, very important program, which was a need of an hour. I extend my heartfelt gratitude to all those who contributed to making this event a grand success. First and foremost, I express my sincere appreciation to our esteemed chief guest, Dr. Ismail, the Secretary APA, and the expert, the most favorite for all of us, the President 2018, Dr. Santosh Sonsas, a known intensivist of the country, whose presence and insightful words have enlightened us. Your valuable time and wisdom means a lot to us, sir, and we are truly grateful for your guidance. A special thanks to the National Coordinator, Dr. Singaravelu sir, and the expert, Dr. Thangavelu sir, for bringing up the second episode of this important EEE program. The a special mention and thanks to our national coordinator, to the national vice president of West Zone, Dr. Ramesh Bajania, sir, for taking up this challenge and bringing out with the best of the faculty, the mentor, Dr. Pamanand, who's a known intensivist and is HOD of intensive care at Jupiter Hospital, Thane. Also, I think a special thanks to our respected faculty members, the other organizers and staff, whose dedication and meticulous planning ensured the smooth execution of the event. Your tireless efforts behind the scene have made this possible. I also extend my gratitude to the participants whose enthusiasm and engagement brought vibrancy to this academic gathering, and your keen interest and curiosity made the discussion are going to definitely make the discussion very more enriching. A big thank you to our technical and supportive staff who worked relentlessly to manage all the logistic aspects to bring out this seamless experience for everyone. Lastly, but most importantly, my heartfelt thanks to our audience for joining us for this activity. And definitely your joining is going to give encouragement to the mentee and mentors and the whole IAP organizing staff. With this, I would like to thank you for your valuable presence over here.
Thank you.
Over
Dr.
to
Ruchira.
Singaravelu, sir.
Singaravelu, sir.
Yes, sir.
Yeah. Just before we end, today is the World Cancer Day, and at 9:15, CIP has organized a program where we'll inaugurate the roundtable discussion, where the cancer discussion would be there, and it would be Dr. Vasant sir and Dr. Basav sir, the president, past president, and Dr. Neelam, the president-elect, will all be present and inaugurate the session. So I would request all the members to please look for the link. We will send it shortly, and to please join at that time. Thank you. Sorry, Singaravelu sir.
Not at all. It's a very important thing, sir. You have done it very nicely, sir, in a good forum.
Yes, me. Julkipil sir, one more task for you. I'm going to send a flyer to you and for that program also. Right? Please.
We'll send it. Thank you. Thank you, President sir, making the program very innovative, very interesting. Now we will go into the academics. Today, our advisor for this program, Professor Thangavel sir, is held up with his DNB exam, and so he is in the exam hall, and where the signal is very poor, so he could not address. On behalf of him, we thank all of them for taking active part in this. Now we will hand over our session to our today's mentor, and the moment we thought of this program, who volunteered himself is none other than our Dr. Pramanand, who is an intensivist. Not only is an academician, he is a very good administrator that all of you will enjoy, as he is admin of our central IAP office bearer, and he made our IAP office in a different 5-star level within a very short spell of time. Apart from his academics, his administration is laudable. Sir, now we are happy to hear your academics through your team, sir. Now I hand over to you. Thank you, Dr. Parman. He doesn't need any more introduction because he is part of us. Thank you, sir. Over to you, sir.
Good afternoon, everyone. Thanks, Singaravelu sir, for those kind words. Respected President, Dr. Khadkar sir, President-elect Dr. Neelam Mohan madam, immediate past President Dr. Basavaraja sir, and today's chief guest Dr. Zulfikar sir, and have an expert like Dr. Santosh Son sir. We'd like to have your expert comments at the end of the case presentation. The Dr. Yogesh Parekh sir, the secretary sir, and the treasurer sir, Dr. Tanu, and the other respected members on the dais. Thanks, sir, for giving us an opportunity to share our cases. So what we have done, we have divided into two parts. One is the case, the dengue, and the second is some interesting case of dilemma. So in this situation, the first, we will present the cases by our intensivists at our hospital, at Jupiter Hospital. We want you all to have a look. They have a different way of presentation. We all have managed dengue differently, And in this scenario, we have thought this is little out of box to treat this dengue with the dengue shock syndrome with different approach of the front management. We want all the expert to have their comments on suggestion and where we can maybe in future have certain this make us the find out that such difficult cases can be handled with different way. With this, I don't waste my time and we'll start our cases. First thing, I will invite Dr. Aditya Modak, who is the junior intensivist at Jupiter Hospital, Thane, and to present his first case. Thank you, sir.
Hello. I'm Dr. Aditya Modak from Jupiter Hospital. We'll start sharing my case with our history. Right, can you see my slides? Hello.
Yes, visible.
Yes, doctor. Make it as a full view. Yes, proceed, doctor.
Yeah. So starting with the first case, this case was a 12-year-old girl at presentation in casualty. Appearance-wise was conscious and alert with tachypnea and with pink color. On primary assessment, the airway was open and maintainable. Respiratory-wise, she was having tachypnea with R of 45, but breathing was regular and air entry was equal bilaterally. There were no retractions, and SpO2 was 95% on room air. Perfusion-wise, there was tachycardia with heart rate of 146, but sinus rhythm. Pulses were poor with BP of 90 by 40 millimeters of mercury with cold peripheries. Child was conscious, alert, and there were no focal neurological deficits. There was generally petechial rash, but there were no obvious external bleeding. So with this presentation, we thought of respiratory distress with shock, and child was started on oxygen support in casualty. IV fluid bolus was given, and maintenance fluids was started. Basic relevant investigations were sent, and child was admitted in PICU. Taking the sample history, the child was having fever since last 4 days. There was nausea and reduced oral intake since 3 days. Urine output was also reduced since last 3 days, and there was generalized weakness, giddiness, and abdominal pain since 1 day prior to admission. Child was admitted in the referring hospital 1 day prior to presentation to us. There were no allergies. In the referring hospital, child had received IV fluids and IV antibiotics. There was no significant past history. Last meal wise, child had not taken orally, kept NBM in the outside hospital, so 1 day she was NBM. There was low BP. The last event is that there was low BP and worsening abdominal pain with worsening giddiness in the referring hospital, and hence they had referred the child to our institute. The reports that are available to us were outside reports on day 3 and day 4 of illness. The CBC trend wise, there was hemoconcentration with HB was 15.9, PCB of 46, counts 5,000, and platelets were 1.4 lakhs, which the hemoconcentration was worsening with thrombocytopenia. That is, HB becomes 17.6 with PCB of 50, counts were 8,000, and platelets were 60,000. The dengue NS1 done outside was positive, and they had done LFT on day 4 of illness, which was showing deranged liver enzymes that HGPT was 1,600 and HGOT was 5,600. Total proteins were 4.8 and albumin was 2.7. INR was not available that time. So this child was a case of dengue shock with respiratory distress. So the questions that came into our mind at that time is how to proceed with this. What should be the investigations? What is the role of colloids? Whether to give any blood products at this point of time. After shifting to the PICU, we continued the oxygen support and fluid therapy. Gradually, the vitals improved. The heart rate has improved from 140 to 110. BP has improved from 90 systolic to 110 systolic. Respiratory rate was 40. CRT has improved to less than 3 seconds. Pulses were also now well fed. And urine output was also coming around 1.7 ml per kg per hour since last 4 hours. So clinically, shock had improved, and the CBC was done at Jupiter showing fall in hemoconcentration. That is, hemoglobin came to 13.9 from 17.6. PCV was from 50 to 44, and platelets were 18,000 at our institute. We did LFT at admission, was showing worsening liver enzymes. That is, HGOT was from 5,000 increased up to 10,000, and HGPT from 1,600 to 2,700. The INR we did was 2.1, and PTD was 116. So with this, friends, vitamin K injection was started for during INA. Platelet transfusion was also given. Now, by the 10 hours since admission, child developed waxing and waning sensorium with intermittent irritability. VBG at that point showing pH of 7.39, back PCO2 was 27, backup was 69, like it was 7.1. We worked up the child between this 10 to 24 hours. From the CBC trend, the HB was 12.2, it became 11, and platelets were 89,000, of course, after the platelet transfusion. INR had improved from 2.1 to 1.9 with vitamin K, and SGOT HGPT has further decreased to 12,000 and 3,700. Creatinine at that time was 0.84, and ammonia was 123. We sent HLH workup, which showed CRP of 45, ESR of 10, and ferritin was sky high, that is 1.56 lakhs. Fibrinogen was low at 73, triglycerides were 257, LDH was deranged to 13,000, and UPCR was 7.1. The VBG was showing lactate slightly improved from 7.1 to 4.7, bicap from 16 to 18. Dengue IgM was at that point was positive. So the working diagnosis was dengue shock with probable developing cytokine storm. So what should be our next role of management? Before coming to the next steps in the management, I will like to share further a few thoughts about how the pathophysiology occurs in certain cases of dengue. It is understood that host immune response plays very important and essential role in the pathogenesis of dengue fever. If you see, there is dengue virus inoculation which leads to viremia. This viremia can cause direct as well as indirect cellular injury. Direct cellular injury causes endothelial cell damage, macrophage activation, and platelet destruction, which presents as severe dengue, that is shock, massive bleeding, and multi-organ failure. However, in certain subset of patients, there can be indirect injury as well. One part of injury is by the antibodies, that is production of antibodies in the form of ADE, that is antibody dependent enhancement, which we'll see later, which can lead to antigen antibody deposition, complement activation, and immune complex deposition. This immune response can lead to vasculopathy and multi-organ injury. On the other hand, it can also cause T cell activation, which can increase the chemical mediators, which again can lead to cytokine storm, which can itself can cause multi-organ injury, coagulopathy, cytopathy, and organopathy. So what exactly occurs in such case? Coming to this one, that is the ENV1 virus, is coming to the endothelium, from where it gets caught by the antigen presenting cells, that is mast cells, and further the macrophage, which leads to the histamine, protein, and other chemokines activation, which leads to increased permeability at the endothelial level, which leads to leak. Also, it can cause complement, the point two, that is complement dependent lysis, that also occurs with the help of natural killer cells. Thirdly, it can induce, due to inflammasome and other IL-1 and other cytokines, it can cause pyroptosis, and at the level of smooth muscles, it causes contraction and vascular leak. It has been known that higher expression of these cytokines conditions the endothelial cells to be more responsive to stimulation by NS1, which further magnifies the inflammation and vascular permeability, that is leading to the further vicious cycle and further worsening of the condition. So coming to what is this ADE, that is antigen antibody dependent enhancement. So see in the part A, that is DENV1 has come leading to stimulation of T cells and B cells, leading to the formation of memory cells. Now, point B here, that is DENV1, that is same virus, that is homotypic reinfection if occurs in a case, then it leads to the formation of memory cells, leading to formation of neutralizing antibodies and a T cell mediated killing of target cells. This neutralizing antibodies causes neutralization of DENV and effective control of DENV infection. However, in certain cases, if there is reinfection of heterotypic virus, that is, for example, DENV2, then these memory cells can produce inflammatory cytokines and non-neutralizing antibodies. This can lead to the formation of antibody-dependent enhancement, and with ongoing inflammation, these children develop cytokine storm and have worsening of their clinical course. So the same thing present in another way. The presentation of virus at the regional lymph nodes leading to the formation of immune response leads to the viral dissemination and immune amplification, leading to the organ injury by the various modes of cytokines. So in our case, it is understood that this child having dengue was having hyperinflammatory response. There was significant hepatic involvement along with coagulopathy. There was encephalopathy evidenced by the vaccine waning sensorium, and the child was also having AKI. Now, how to proceed further? The pointers for our proceeding was, first is the managing the airway breathing and circulation. What should be the fluid therapy? How to manage the HLH? What should be the immunomodulatory therapy? What is the role of steroids, plasmapheresis, or any other immunomodulatory agents? And lastly and importantly, supporting the organ failure, that is liver, kidney, and brain. And what is the role of extracorporeal therapy here? For example, hemodialysis, CRRT, or SLED. So this child was electively intubated. Central and arterial line was secured under cover of cryo PPT as well as platelets. Child was ventilated mechanically and child maintained on the PRVC mode with baseline settings. We did CT brain, which was suggestive of developing mild cerebral edema. We involved our pediatric rheumatologist into care, and child was started on 30 milligram per kilogram injection methylprednisolone and cyclosporin as well. So by this, we have done the airway breathing circulation immunomodulatory therapy we have started. Now, how to go further about managing the cytokine storm? What is the role of extracorporeal therapies here? What we did by this time, 36 hours of admission has gone, and we did one cycle of plasmapheresis, and child was started on CRRT with addition of cytosol. Child started developing hypertension and oliguria, that is urine output was around 0.4 ml per kg per hour. Hence, cyclosporin was stopped, being a nephrotoxic agent. CRRT was continued with additional ultrafiltered removal. We started arrangement for anakinra simultaneously. So, what is the evidence for this extracorporeal therapy? This is a study from Vietnam that included 19 children conducted between 2018 to 2022, which concluded that the CRRT as well as addition of plasmapheresis both together reduced the mortality to 37% compared with the standalone therapy, where the mortality can go as high as 87%. So this was the conclusion, that is, both alone and in combination with other therapies such as CRRT improves liver function, survival rates, as well as neurological outcomes in patients with dengue fever. Comparing with the extracorporeal therapy, that is CRRT and IHD, the CRRT, as we all know, that has more control removal of the fluids as compared to IHD. Plus, it is safer for the hemodynamically unstable children. The other studies also show that there is the probability of renal recovery is faster and better in the CRRT compared to hemodialysis. Hence, the CRRT was chosen and plasmapheresis was also continued. Now, we also give applied cytosol with CRRT. So, what is this cytosol? Cytosol is a highly biocompatible porous polymer. It works with the mechanism of adsorption. So, this is a cytosol which contains small beads inside it. As the blood passes through the cytosol from one end and comes out to the other end, with the mechanism of adsorption, it removes certain chemicals from the body. The chemicals can range from pro-inflammatory as well as anti-inflammatory products, includes proteins, hormones, as well as drugs, cells, and antibiotics also. It is known that it can remove. So this is a diagram to show before and after blood purification, how the system changes. The green in the first part of the diagram, the green are the bacteria, plus signs are the cytokines, and lastly are the leukocytes. In the blood vessel, you can see there are a lot of cytokines, which are, because of the gradient from the tissues to the blood vessel, are coming into the circulation. However, after the blood purification with the extracorporeal therapy, you can see that cytokines are effectively removed, along with removal of bacteria as well as the WBC. Now, the learning from our COVID times is that what used to happen in certain subset of patients, that there was viral infection leading to the pneumonia, leading in some cases, leading into the mechanical ventilation as well as dialysis. We have seen that there was the hyperinflammatory response, that is systemic cytokine release, which was mediators of pro-inflammatory cytokines as well as anti-inflammatory cytokines, which damages the organs, leading to endothelial dysfunction, shock, and multi-organ failure. In that case, we have seen that there is a lot of pro-inflammatory cytokines in the initial phase can lead to early death because of the overwhelming inflammation. On the other hand, due to the excessive anti-inflammatory response by the patient or by the iatrogenic like medications, there can be late days due to the reinfection or the secondary infections. So word of caution here is that this cytoxan has to be used with caution because it removes pro-inflammatory as well as the anti-inflammatory cytokines. So after around a day of CRRT, we did a repeat parameters which showed HB of 8.7, hematocrit was 25, platelets were 80,000. Ferritin has significantly reduced from 1,56,000 to 13,000. Creatinine was 1.4 and SGPTOT has significantly improved to 1,000 and 1,800. INR was also 1.8 and lactates, bicarbonate lactates were also in the improving trend, that is 21 and 2.8. There was hypertension and one more cycle of plasmapheresis was done prior to CRRT. Urine output was 37 ml and we removed excessive ultrafiltrate because of the olivia, that is 750 ml. So here now we are managing the cytokine storm, organ failure with CRRT and plasmapheresis. We are suppressing the immune response with our steroids, but we had to stop cyclosporine because of the AKI. Is there any other agent which can be used for immunomodulation in this case? So this is the umbrella of cytokine storm, that is cytokine release syndrome, cytokine storm syndrome, or MAS HLH, which in which there is IFN gamma and other cytokines which are involved, leading to the pathology. There are various agents available to treat that. Depending on their mechanism, they have immunosuppression action as well as anti-inflammatory action. So we have to be careful while choosing which predominant action we want and which fits our case best. So coming here, the red part is the immunosuppressive action and the green part is more of anti-inflammatory action. So in our case, we couldn't use cyclosporine. We are already using steroids because child was having AKI and already plasmapheresis and CRD was ongoing. IVIG was not considered. And we considered anakinra here because we can see that there is minimal of immunosuppression and more of anti-inflammatory action. So anakinra was chosen. This is a supportive study done in India itself, in Kolkata, where the use of anakinra used in secondary HLH in a case of severe dengue had a very good outcome. So we could arrange anakinra and started on 25th, that is around day 7 of illness, and pediatric rheumatology reference was also ongoing. Despite of that, child continued to be oliviric with incomplete response to diuresis, and there was positive fluid balance. The report trend was showing improvement in the liver profile and improvement in the blood gases also, but the creatinine was increasing, that is from 1.4 to 2.4. Platelets were stable at around 80,000 to 89,000. Ferritin was improving from 13,000 to 4,600. The urine, so we did one plasmapheresis and CRT, we restarted the second cycle and removed ultrafiltrate around 2.6 liters this time. So in the last 24 hours, the fluid, the urine output total removal was 2.9 ml per kg per hour. So after the next day, the parameters were repeated, which showed further improvement that the HB was 7.3, ELC was improved to 7,800. Ferritin had improved from 4,600 to 3,300. Creatinine improved from 2.4 to 1.8 and liver enzymes showed further improvement to 400 and 500 around. Blood gas was also in an improving trend, that is pH of 7.4 with bicarb improved to 24 and lactate also improved from 2.6 to 1.5. By the day 9 of illness, the child was also showing clinical improvement. Hypertension was also controlled with nifedipine sustained release tablets and urine output also started improving spontaneously, which remained around 2 to 3 ml per kg per hour in last 24 hours. So the investigation trend wise, being a big number, I will just enumerate the important factors. The hemoglobin had dropped to 6.6, which managed with PRBC transfusion. Platelets were lingering around 50 to 60,000. Ferritin was showing an improving trend. Liver enzymes were also showing improving trend. The creatinine was slightly higher till 1st of October to 5.7, which also showed later on improving trend. The plasmapheresis was done 27, 28, and on the 2nd. So this is the graphical representation of the trends in the investigations, where you can see that LDH had the ferritin has showed significant improvement from the day 1 of 1.6 lakhs to as low as 14,000 eventually. LDH also from 13,000 and improved to up to 700. The platelets were remaining around 80,000 and 89,000 overall. So clinically, the plasmapheresis and anakinra was continued. The total 5 cycles of plasmapheresis were done. from a period of around 9 to 10 days. Methylprednisolone 30 mg per kilogram was given for total 5 days and then tapered to the injection dexamethasone to 10 mg per meter square. By day 13 of illness, we could extubate the child to NIV and child tolerated well. We continued the other supportive management. Antibiotic-wise, we gave meropenem and fluconazole was also added. After 2 days, around on 4, the child had a GI bleed in the form of melena with there was fall in hemoglobin to around 4.8. If you see the platelets were in an improving trend from 61,000 to 82,000 and INR was also in improving trend from 1.8 to 1.6. We gave one vitamin K and this bleed was attributed to the steroids as well as the ongoing stress response. So steroid dose was tapered, injection pantoprazole infusion was started and PRBC transfusion given. 2 aliquots per day was given 10 ml per kg. After that, the PRBC, the hemoglobin improved to 5.7 and subsequently to 7.4 as well. On CBC, on serial CBCs, there was no further bleed. However, child developed thrombocytopenia. There was no bleed, but peripheral smear was also showing normal size platelets. There was no evidence of bacterial or fungal infection. So pediatric hematologist was involved in care, and child was given injection romiplostin. After the injection romiplostin, there was no further worsening in the thrombocytopenia, and there were no bleeds from any sides, and the platelets were started showing improving trend to 35,000 and 88,000 also. The child was vitally stable on room air. Blood pressure was under control with nifedipine. CBCs were also showing improving trend. Hence, child was shifted to ward by around 20 days of ICU. Injection meropenem was given for around 3 weeks. Steroid was made oral and tapering was also started. However, in the ward, after around 2 days, we noted that child was having lower limb weakness and thought of critical care neuromyopathy. We did NCV, which showed motor polyradicular neuropathy involving both lower limbs. We involved our pediatric neurologist into care and neuro rehabilitation measures were started. By day 24 of hospitalization, that is after 4 days into the ward, child had sudden one episode of seizure, which was focal in the form of left-sided deviation of fits, with staring look around for less than 1 minute. BP was at that time around 150 by 110. So one tablet Nicardia was given in ward and child was shifted back to PICU for blood pressure management and continued monitoring. We added tablet carvedilol into the medications. Ophthalmic evaluation was done, which was showing no papilledema. We did CT brain with plain plus contrast, showed subcortical white matter edema in left parietal and parietal occipital region. The differential were considered as post-ictal phenomenon versus fresh changes. Renal Doppler was normal, urine output was also normal. BP came under control just with nifedipine and carvedilol. The urine output was normal. There were no further episodes of seizures and there were no clinical setbacks after that. This child was shifted back to the ward after total around 72 hours of observation into the ICU. Neuro rehabilitation sessions were continued. Antihypertensive medication doses were adjusted as required as per the blood pressure trends. And child was discharged on 25th of October on nifedipine and carvedilol. So after around 4 weeks of hospital stay, we could discharge the child. So summing up with this case, this was an adolescent girl presented in around at the end of first week of illness. Child was having NS1 as well as IgM positive, presented with cytokine storm with multi-organ involvement. So the treatment given was immunomodulation, extracorporeal therapies, and organ supportive therapies, to which the child responded well. This was the first long case. At around similar time, after 2 days of this child's admission, we came across another case. I will like to present shortly 2 more cases which had almost similar presentation of dengue but having slightly different manifestations. So this was a 2.5-year-old female child having complaints of fever, cough, and cold since last 8 days and was afebrile since 1 day prior to admission. Having poor oral intake, had vomiting since 4 days, abdominal pain and reduced urine since 3 days, and there was altered sensorium. Child was not recognizing parents and intermittent extreme irritability since last 2 days. There are around 3 to 4 episodes of convulsion 1 day prior to admission. With the above complaint, child was admitted to our referring hospital. Their child was treated with antibiotics, Luvir, 3% NCL, considering age, ICP, injection, mannitol, IV gamma, and IV fluids. Child was referred to our center for further management. And during transportation also, child had 2 episodes of convulsion again, which was and was loaded with levetiracetam. MRI brain was done outside, which showed post-infectious encephalitis. The reports that were available to us for that dengue, NS1 was negative, malaria was negative. They had done CSF outside considering the conversion with fever. The cell count was 1 with protein 17 and sugar was normal. The CBC was showing hemoglobin of 10.6 with PCT of 35, ELC of 9,800, thrombocytopenia with platelet 24,000, and deranged liver profile. That is, INR was 2.1, FPDT was 135, and SGOT was 12,000, and SGPT was 690. The LDH was also raised, that is 9,100 when the child came to us. On examination, when child came, she was afebrile with heart rate of 110 and RR of 18. Saturation was 85% on room air. Pulses were feeble with cold extremities, and BP was 140 by 80. GCS wise, her GCS was 8, pupils were equal. Otherwise, there was no neurological deficit. There was ongoing oral as well as nasal bleeding, and on the abdominal examination, there was hepatomegaly. So, impression was febrile encephalitis. So in casualty, we intubated the child, gave NS bolus followed by maintenance IV fluids. Additional extra NS was also started, gelfusion was started. One vitamin K was given, and right femoral central line was inserted. Injection noradrenaline was also started for. On the significant RT and nasal bleed, we involved our gastroenterologist. The sucralfate and NAC was given. Pantoprazole infusion was started, and injection vitamin K was continued. We gave anti-edema measures as 3% NaCl, anticonvulsants, injection Levipil and phosphonitoin added, and meropenem was given for antibiotic cover. The reports at our place was hemoglobin was 5.6, possibly because of the ongoing bleed. The TLC was reduced from 9,000 to 5,600, and there was significant thrombocytopenia. That is, platelets were 4,000. The INR at our institute was 2.4 with ability of 105. And dengue IgM had come positive at this point of time. The electrolyte was sodium 130 and potassium was 5.5. Albumin was low at 1.4. SGOT, AGPT was both deranged at 12,000 and 2,900. The ferritin was also elevated to 2,400. Fibrinogen was low to 73 and LDH was 9,500. UPCR was also elevated to 10. So, considering there was dengue, NS1 negative, but IgM was positive, and there was cytokine storm with significant liver involvement. So, we gave FFP transfusion, cryoprecipitate, and vitamin K to improve the coagulopathy. So, this was a dengue hemorrhagic fever with fulminant hepatitis with coagulopathy and cytokine storm. Injection MPS was started, and first cycle of plasmapheresis was done with equal replacement with FFP was done. On further trends, if you see, there were 3 cycles of plasmapheresis were done, and there was improvement in the trends. That is, ferritin improved from 2,400 to 1,400. LDH improved to 9,000 to 4,000, and eventually to 1,700. CPK was 319, UPCR was 10.3. Liver enzymes showed improvement from 12,000 and 2,900 to 7,000 and 1,800, and 2,800 to 1,000. The INR was also in the improving trend, that is 2.4 to 1.5 and eventually 1.4. So, with just 3 cycles of plasmapheresis, we could taper the extra NS, we could taper and stop the gelfusion. We also, as the perfusion was also improving, we could also taper and stop injection noradrenaline. The CBC that was last done was showing further improvement, that is HB 10.4 with platelet 65,000 and WBC 8,400. Unfortunately, because of the financial reasons, child couldn't continue with us and was shifted to one government setup. There in government setup, we could know the follow-up, where after 2 days, child was successfully extubated and did not require any further major interventions, including any extracorporeal therapy as well. So on follow-up after discharge, the child is neurologically normal and doing well. So summing up this case, this was a 2.5-year child. The previous one was an adolescent. This presented in second week of illness. In this case, the NS1 was negative, but IgM was positive. This was the predominant CNS and liver involvement along with coagulopathy. The cytokine storm was there, but was not that severe compared to the previous case. And this case responded just with steroids and 3 cycles of plasmapheresis. Didn't require CRRT as well as other immunomodulatory agents. Fortunately, around this similar time, we again received third case within 2 days of these 2 cases. This child was infant, that is 4 months, with having complaints of fever since 5 days. Was admitted outside where developed one paroxysmal event, 2 episodes of generalized tonic-clonic seizures. And because of that, child was shifted to our
Doctor,
hospital.
just 1 minute, sir. Before proceeding further, these 2 cases, can I get some expert opinion from Dr. Santosh, sir, before going to the 3rd case?
Sir, this is the continuation of the case. Just let that 1-2 slides only. We will finish it and get it, sir. Is it okay?
Okay. I think it should be okay if you're finishing.
So the child shifted to our hospital for further
Santosh, sir.
management.
Aditya, just fast. Last.
It should be fine. It should.
Yes, sir. So on examination, there was the heart rate was 150 with tachycardia, BP was normal 10660. There was feeble pulses with cold peripheries. Otherwise, systems were normal apart from CNS, where the child was drowsy, but pupils were equally reactive. That the investigation was showing thrombocytopenia with platelets 95,000 and dengue NF1 was positive. So impression was infantile dengue with suspected dengue with encephalitis. So investigations at our place were showing HB of 11.9, hematocrit 37, platelets thrombocytopenia platelet 30,000. INR was deranged to 4.6, but liver enzymes were not that deranged, that is 370 and 107, and period of acceptability is 0.24. Electrolytes were normal, but dengue IgM was also positive. So in view of deranged PT and IM, vitamin K was started. Child again had 2 episodes of JTCS and our hospital at the same day of admission, which was subsided with midazolam, and child was reloaded with Levipil and maintenance dose was continued. The ferritin we sent was high again, that is 2,400. We had planned to, considering a cytokine storm again with an infant, we had planned to start steroids as well. However, there was clinical improvement. There were no further seizures, fever spaced out and subsided. Repeat investigations also showed improvement, that is, hemoglobin improved to 8.7, hematocrit was 26, INR also improved from 4.6 to 1.1 just with vitamin K, and PTT was also improved. Liver enzymes also improved from 3 digit, that is 107 to 300 to 95 to 300, and ferritin improved from 2,400 to 1,900 as well. So child was clinically better, no perfusion was good, urine output was also normal. Further trends, investigations also, there was improving trend in the platelets and hemo concentration. Liver enzymes also further improved, ferritin also further improved. So we could stop the extra NS, child was orally accepting well and no further seizures as well as fever. And we could discharge the child within 2 days. So the peculiarity of this case was this was an infantile dengue present at the end of first week. Both NS1 and IgM positive, and there was relatively less inflammation and relatively less liver involvement, and didn't require any immunomodulatory agent. Just the child showed a spontaneous recovery after this. So summing up, the dengue can have various modalities of presentation case to case. So first case was actually a complete storm. The second case was a flood, and third case was just the rains which subsided without causing much of a damage. So considering this as a prism, I have one ray of light comes, that is the dengue virus. However, the response can be anywhere. It can be a spectrum, and that is from violet to the red. So depending on the case to case, the response can be different in individual cases. Since you can't treat all kids the same, and same, it is questionable whether the same protocol for managing severe dengue will be effective for all cases. We may have to treat individually and accordingly act depending on the response. Thank you.
Yeah.
Wonderful presentation, Doctor. Over to our expert, Professor Santosh, sir.
Yeah, thank you. It was a great presentation, Aditya. I think you went through the spectrum, what dengue can do in a different age group and different way our body can respond to this with the cytokine storm. As you rightly said, that the first case we had a real storm. It was like a storm, like a hurricane, which storm was there. And as you came on the second, it was much lesser, and the last one was much lesser, just improved like this. So this is, if you see dengue, the secondary HLH like symptoms or cytokine storm, what we have seen, it's a because if you see in India, I think last 2-3 decades, we are seeing this dengue. Basically, last 2.5 decades, we have been seeing epidemics of dengue, and people are the most important thing is getting sensitized, because they would treat to dengue with a lot of fluid, and we had a lot of problem. Then came this secondary HLH, which was missed initially. A lot of then with the sensitization, people started picking up, treating with steroid. Those days, the steroid was the immunoglobulin. Only thing is, when you present, what happens is all this many drugs which are not available in the peripheral setting, smaller hospitals, government hospitals, especially Anakinra, then your cytoabsorption, that is your blood purifying systems and all that. Though I have only couple of cases of experience with cytosorbs, which is very expensive, and only few places we can do it. And other this thing, like you have this romiplastin is one more drug. But only thing is, what I would suggest also, like when we hear this name, our hand itches to write that when we see this chronic thrombocytopenia or acute thrombocytopenia, which is not responding to IVIG or this thing. But what I advise is that when you use this drug, please take a help of a pediatric hematologist, and then only, because we don't have the long-term studies on this thing, what it's going to do to the pediatric age group. So please take this thing. And basically, it's very difficult to, as an intensivist, to predict or see the future when we have a child with a cytokine storm, how he is going to develop. It's a day-to-day basis. There is no scores which I say with this, like our Apache score or any of the Phoenix score or anything, where we can say that, okay, this is going to do much better and this is going to do a much worse. It's very difficult to predict. The cytokine, anyway, it can go. I think a place like Paramanand's place, where they have everything there and all the facilities and all that, I think especially the first one really did well with this thing. But most often, all this thing, where in the government hospital, I was asking my colleagues also about this, they're using the steroids also. Few places now the government is giving immunoglobulin free of cost, so they can be using these drugs where the hematologist is there, anakinra is being used, and the other drugs are being used for this cases. So it is very important, as I said, the essence of the experience is that to pick up the cytokine storm early and then treat the thing. I'm very happy that the second case also was something on a different spectrum, which went on, which improved with much minimal management, as when you compare to the first one, last one put this thing. So it really gives you a spectrum, I think, for the pediatrician or a pediatric intensivist who we are there. It basically shows that anything can, when the child presents very sick, you have a different 3 categories of this thing. One, as he said, the storm; second was flood; and the third one was the rain. Very nicely presented. I thank you, Paramanand and Aditya, for a wonderful presentation and wonderful wonderful outcome also. Congratulations for especially the first one, to bringing him out of this terrible storm. Thank you so much.
Thank you, sir. Thank you.
Thank you, sir.
Dr. Julpikil is there. Dr.
Yes.
Julpikil.
Yeah, I think it's a very brilliant presentation, and as Santosh said, it's like you've gone through the whole spectrum. I mean, HLH, hemophagocytic lymphohistiocytosis, is very rare in children. They see it a lot in adults, but rarely in children. And I must admit, you've done very well with the first case. It's not I think most children who presented like that and went through the course that this child went would probably have died or have had neurological deficits. I assume that your child survived without any neurological deficits.
Yeah, no neurological deficit.
Yeah, probably Indian children are stronger. They probably survive. Anyway, congratulations. It's very good. Your last case was the NS1 second case. Was it? The NS1 was negative, but the IgM was positive, and this was after 2 weeks of illness. This is expected. And I think this is something, a take-home message for those who are working in the outside in general practice, that when you see a child who's had fever for about 2 days and you do a DNS1, you don't really expect it to be positive, because the NS1 will actually come up, and with the viremia come down by about the 4th day or so, and the IgM will start to come up. So by 2 weeks, you would expect the IgM to be positive. Well, thank you very much for those presentations. It's very, very nice.
Thank you, sir. Thank you.
तयार करू इमिजिएटली ती तयार व्हायला पाहिजे.
Dr. Singarvelu? Yeah.
हा ते चांगलं नाही वाटत आहे, एकदमच कशी वाटत आहे.
So the
Yes,
thought
sir.
was
Very nice presentation and very well discussed. And Dr. Pramanand sir, it's your time.
आणि ते ना एक मिनिट,
Pramanand
the
sir,
thought process would, yes, sir.
please take over.
आठवलंय का?
Yes, the thought process came as a storm. You have to act urgently. So the concept here was to remove the cytokines from the body. That's the reason why, either by dialysis, by the cytosorb, that was the purpose of using it. There's a pros and cons. If you use prolonged period of time, there can be a problem. And the concept of using Plex or the plasmapheresis was to remove the antigen antibody and replace it with the plasma. And when you are removing the antigen antibodies, we are removing the cytokine storm, but the body may continue to produce the cytokines. And to suppress that, that's the way we use the steroids. And when the steroids are not working, we start thinking of what else. And that's what the thought process with the rheumatologist was, the anakinra. It's a combination of all these three. Which one can go, suppose use more or less, can harm the child. The outcome can be different.
Why
so that
we are getting late in Zoom link?
which is required. And what we could do this was a thought process behind it. The second patient which presented late, we thought it's not an antigenemia which is causing a problem or a storm. The ferritin was not that high. It may be an antibody dependent enhancement which is causing a problem, and that's the reason we thought of giving a Plex. So doing a plasmapheresis removes those and supplement with the fresh plasma, and dramatically it's helped. The coagulopathy improved. This outcome also was good. In the third phase, which we are waiting, and the spontaneous, the judgment of deciding about the drugs is very crucial. So we have to be on toes and decide on the spot with the help of our expert, Dr. Vijay Vishwanathan for the rheumatology. Dr. Ratna was there for hematology. We used the rheumaplacin after conducting the hematologist only, and that we have taken the nephrologist, Dr. Hariket Hase's help. So we could manage, and luckily all these patients were simultaneously there, and we could. That's the reason it would help us to manage all these things. Thank you, sir, again. And with this, we stop this case and we can go for another patient, which is more another interesting intra patient, which has not come out of the anesthesia. Thank you, sir.
Thank you, sir. I think if there are no more questions, we'll proceed to the next case. Thank you, sir. In the meantime, Paramanand sir, go through the chat box. You can answer at the end of it. Okay, sir.
Yeah. Siddharth, I will invite Dr. Siddharth to present the next case.
Yes, sir. Good afternoon, everyone. I would like to present my case. This is an 8-year-old child with history of fall at home, followed by left leg swelling and pain and restricted movements. X-ray showed compound fracture of the left femur shaft. The patient was admitted outside hospital and taken up for open reduction of fracture femur on the very next day. Post-operative course at the outside hospital. Surgery completed under general anesthesia and child was shifted to recovery room. However, patient was not spontaneously breathing and was unable to regain consciousness, hence was unable to extubate. Gradually, child was started having poor peripheral perfusion, so started on dobutamine infusion and referred to Jupiter Hospital by second day evening. The investigations that were done on outside, the pre-op workup was unremarkable with hemoglobin of 9, counts of 17,000, platelets were adequate, electrolytes and liver enzymes were good. However, the very next day post-op, we can see significant fall in hemoglobin and baseline creat was not available with us. However, on the next day post-op, when the child could not be extubated, they again repeated the panels, which showed a creat of 1.4. So we can see anemia and AKI setting in. So once the child reached the casualty, we noted that the child's GCS was 3. She was afebrile with a heart rate of 130. On bag and tube ventilation, we found that it was difficult to ventilate, needing very high pressures for bagging. Saturations were hardly 85%. Peripheral pulses were not felt. Central pulses were poorly felt and peripheries were cold. CRT was delayed and BP was not recordable. On systemic examination, there was tachycardia, no murmur. Air entry was bilaterally present. Bowel sounds were present, no organomegaly. As I said, GCS was 3, pupils were more than 5 mm, dilated and equally dilated, and they were sluggishly reacting to light. Local examination showed that there was left leg mid-thigh swelling and decreased movements of all 4 limbs to the tune of suggesting quadriparesis. So our provisional diagnosis was respiratory failure with encephalopathy with hypotensive shock. And differentials that we considered where it was probable hemorrhagic shock due to significant bleeding intra-op, whether it could be metabolic encephalopathy, or whether it was just an hypoventilation and leading to respiratory failure and multi-organ involvement. So on admission, we did a blood gas which showed severe respiratory acidosis with PCO2 of 82 with a pH of 6.9. PO2s were hypoxia was there with 61 on bag and tube ventilation, bicarb were 19, hemoglobin was 5.4, saturations as I said 85%, and lactates were raised to the tune of 5.3. Child was continued on bag and tube ventilation with thought of hypoglycemia. Sugars were checked, it was 35, D10 bolus was given. Fluids were started, considering hypotension, adrenaline infusion was started. And a screening 2D echo was done, which showed a normal cardiac function. So we thought of taking ventilation corrective steps. As I said, it was difficult to ventilate with a severe respiratory acidosis. We thought of checking about dope. So we did a direct laryngoscopy, which confirmed position of the ET tube, which can be seen on the X-ray as well. However, we noticed that the cuffed ET pilot balloon was found to be very tight with high cuff pressures. So after deflating it, ventilating the patient got easier and gradually child started having cough reflex and eye opening. So this is a repeat blood gas 2 hours post the ventilation corrective steps, which showed significant improvement in respiratory acidosis with pH improved to 7.1. There is improvement in hypoxia. However, lactates were consistently in high range. So circulation-wise, anemia was 5.4 with a tense swelling at the surgical site, that is left femoral side. Emergency blood transfusion was arranged, O negative blood. Fluid resuscitation and inotropic support was continued. Gradually, the perfusion improved and central pulses, radial pulses also improved. However, lower limb pulses were still poor. So the cause of quadriparesis was still unexplained to us because even after taking ventilation corrective steps, child was unable to move the limb. However, the eye opening was present. So we thought of whether there could be a possibility of atlantoaxial dislocation that could have happened during the surgery or during shifting the child. So to rule out the dislocation, we did CT brain. Along with it, we did CT chest also, which was normal. Patient was started on antibiotics, blood transfusion was continued, and child was shifted to PICU for further care. In PICU, we noticed that child sensorium gradually improved with eye opening. However, as I said, all the 4 limb movements were still weak. Ortho team was involved. Distal pulses were poor, so Doppler screening was done, which was normal, and child was monitored for features of compartment syndrome. This was the X-rays of the child, the plate fixation of the fracture femur, which was done outside, and the chest X-ray. So this was at the time of admission, blood investigation at the time of admission. Hemoglobin was 5 with what we can see, there are issues of anemia. INR was raised to the 3.2 with prolonged PTT, so there was coagulopathy. Creatinine was raised, which was 1.4 in the referring hospital. It has increased to 1.7, so there was issues of AKI. HG OTPT were raised, so it was a picture of transaminitis with liver failure, and we suspected that the child was not able to move a limb, so we suspected there could be possibility of muscle injury. So we did CPK, which were high. So we thought that there could be some possible inciting agents which could lead to the muscle injury. We stabilized the child by giving PRBC transfusion, FFP, and vitamin K. So probable differentials were for the coma, we thought of it could be case of CO2 narcosis leading to type 2 respiratory failure, triggering cascade of coma, hypotension, and hypoxia. There could be component of hypoxic ischemic injury to the brain due to hypoventilation and multi-organ involvement. And we thought of whether there could be possibility of anesthesia-induced rhabdomyolysis and multi-organ involvement. On inquiry at the referring hospital regarding the agents that were used during the general anesthesia, we came to know that use of succinylcholine was used during the induction of general anesthesia. So hereby we present a case where we have come to know that like succinylcholine along with use of halogenated anesthetics can lead to rhabdomyolysis in susceptible individuals. So coming to CO2 narcosis, there are three mechanisms by which it can lead to CO2 narcosis. First one is the decreased minute ventilation, where it can be seen with excessive sedatives, stroke, or hypothermia. Second one is increased physiological dead space, where there is in situations like asthma and pulmonary embolism. And third one is increased CO2 production, like sepsis, thyrotoxicosis, or excess supplemental O2 in neuromuscular diseases, COPD or PPD. So in our case, risk factors were there were possibility of excessive sedatives at the time of anesthesia or anesthetic complications, as well as positive pressure ventilation complications, as we came to know there was increased cuff pressure at during the casualty. So just coming to the symptomatology of acute hypercapnia, with rise in CO2, first is the onset of headache with mild dyspnea, tachypnea, and somnolence. With rise in CO2, ultimately the patient goes into the delirious state, confusional state, and depressed level of consciousness. And ultimately, we have seen when the CO2 level surpass 75 mm of Hg, we have noticed that any patient goes into the coma and bradypnea. So here we just did a literature search which showed us that endotracheal tube cuff overinflation can lead to hypoxic cardiac arrest. So they have mentioned that the herniation of endotracheal tube plastic lining into the lumen or around the end of the tube results in airway obstruction. In addition, an overinflated cuff can exert an increased tracheal pressure leading to restriction of mucosal blood flow, resulting in ischemic complication. Also, hyperinflated cuffs may also incur damage to the intralaryngeal portion of the recurrent laryngeal nerve and cause post-extubation hoarseness. So it was a multidisciplinary involvement. Orthopedic team was involved for the fracture femur part. They did serial Dopplers and limb movement assessments were done. Anesthesia team was involved where they thought that anesthesia related complications could be a possibility. Neurologists were involved. MRI brain was planned after stabilization, and also NCV was done, which showed mild prolonged latency. N-acetylcysteine was started for transaminitis. Now, 12 hours post-admission, the overnight consciousness was improved. However, child had continuous drop in urine output up to 0.5 ml per kg per hour. So fluid challenge was given and also blood supports were given along with diuretic challenge. However, child continued to be oligoanuric. So peritoneal dialysis was planned in view of AKI with worsening metabolic acidosis. Here we can see the next day, that is after we received the child, the next day the pH has worsened from 7.28 to 7.29, and bicarb has reduced from 15 to 11. So in view of this worsening metabolic acidosis and AKI part, we decided to go ahead with peritoneal dialysis as child was hemodynamically unstable and lesser risk associated with bleeding manifestations. So we went ahead with peritoneal dialysis. Now, for causes of AKI, in our case, whether it could be first, it could be the hypoxic damage leading to multi-organ involvement, and second was the rhabdomyolysis induced myoglobinuria. So, how to diagnose or suspect skeletal muscle involvement and intervene early? So, what is rhabdomyolysis? It's just the lysis of skeletal muscles leading to influx of myoglobin, potassium, phosphate, and lactate into the extracellular fluid. Symptomatology wise, locally, patient can complain of limb weakness or myalgia. Systemic, we can find there could be possibility fever, cola colored urine, nausea, confusion, agitation. Diagnosis depends upon CPK and urine myoglobin levels predominantly. However, accessory components like burn creat, SGOT, hypocalcemia, hyperkalemia, they can be derangement. Management wise, fluid, alkalization of the urine, and dialysis. Potential complications associated with rhabdomyolysis are acute renal failure, which to be managed with dialysis. There could be compartment syndrome, which may need decompression fasciotomy. DIC should be managed with blood products. Dyselectrolytemia, in those cases, life-threatening arrhythmia should be managed. So how does the rhabdomyolysis leads to AKI? There are three mechanisms. One is due to rhabdomyolysis, there is excess production of platelet activating factor and endothelin 1, which can lead to renal vasoconstriction and cause hypovolemia. Second is due to there could be cast formation with TAM horsefall protein, which can lead to tubular obstruction. Third one is due to myoglobin breakdown into protein and heme ion moiety under acidic condition, and this can directly cause toxic radical induced damage to the kidney tubule. So on day 4, child continued to be on ventilatory support with ongoing peritoneal dialysis. Vitals wise, child was stabilized on ventilator, and as blood pressure and perfusion improved, inotrope support was tapered and stopped by 72 hours after admission. Left lower limb edema continues to be present, however, perfusion and pulses improved. So this is the blood investigation trend in the first 72 hours. With PRC hemoglobin, with PRBC transfusion, hemoglobin improved. However, there was drop in platelet count. The liver parameters wise, INR got improved from 3.2 to 2.1. PTT also from 75, it reduced to 35. However, we noticed that the creat had a rising trend. AKI was worsening from 1.7 to 2.59 to 4.5. SGOT-PT was also deranged, and CPK showed significant worsening to the tune of 80,000. So issues were rhabdomyolysis that can causing DIC and AKI, and there was transaminitis, which could be due to the ischemic hepatitis secondary to shock, or even rhabdomyolysis can lead to increase in the transaminitis. So these are the possible causes of rhabdomyolysis. Could be genetic, where we have metabolic disorders, mitochondrial disorders. It could be anesthesia related, where propofol infusion syndrome, muscle channelopathies, anesthetic agents like succinylcholine, halogenated anesthetists are involved. And acquired could be drugs, toxins, infections, crush injury, ischemia, metabolic disturbances. So in our case, we have 3 risk factors that we could isolate. Initial was crush injury or compartment syndrome. Second one was the hypoxic ischemic injury that the child had suffered during the transport. And third one was the possibility of anesthesia related complications. So these 3 possible mechanisms could explain the cause of rhabdomyolysis in our case. We also sent, suspecting rhabdomyolysis, we had also sent urine myoglobin, which were more than 30,000. Carnitine deficiency is known to be accentuate the rhabdomyolysis secondary to anesthesia and metabolic myopathies. So carnitine supplementation was also started. On day 4th and 5th of admission, child weaned off sedation. She was completely conscious, responding to verbal commands. Lower limb edema had reduced, no hemodynamic instabilities. So peritoneal dialysis was continued for 3 days and adequate negative balance was achieved. You can see the trends with hemoglobin had improved with PRBC transfusion. However, there was a worsening thrombocytopenia, which was supported with platelet transfusion. The INR had improved, and SGOT-PT had also started to improve. So after 72 hours, we planned to stop the peritoneal dialysis. We had noticed the child went into hypertension, so nifedipine was given. So issues, transaminitis, hyperkalemia, and metabolic acidosis improved. However, child continued to be anuric and uremic and hypertensive also. Hence, HD catheter was placed prior to extubation for an anticipated need of hemodialysis due to pigment nephropathy. So here we can see CBC and electrolytes were stabilized. However, AKI and ischemic hepatitis transaminitis component was still there. However, gradually with PD, CPK has started to reduce. So child was extubated to NIV on day 8 of admission. Sensorium was good. Due to anuria, we had further given one fluid challenge with Lasix after stopping PD. However, there was no improvement and child continued to be anuric with metabolic acidosis. So one cycle of HD was done. The uremia improved from BUN reduced from 45 to 29. Creat also reduced from 6.6 to 3.3. And CPK also had fall further to 15,000. Child developed new onset fever. So we had sent blood and urine cultures. Antibiotics were escalated and prophylactic antifungals were started. Within 24 hours, we got our culture reports. Blood culture was sterile. However, urine culture grew E. coli and Enterococcus faecium, which was sensitive to meropenem, which had started initially, and teicoplanin was added according to the sensitivity report. By 10th day, child had persistent hypertension requiring antihypertensives. Urine output was still low, and so we planned for second hemodialysis. However, here we can see for the initial 8 days, the urine output was in the range of 0.1 to 0.2 ml per kg per hour. But with post 2 cycles of hemodialysis, the urine output gradually improved from 0.2 to 2.3 to ultimately 4.9 ml per kg per hour. Simultaneously, we had started oral bicarb in view of persistent acidosis. So here we can see in the blood gas component with post HD on day 14 and 15, the pH has normalized, bicarb has also normalized, and lactates has reduced to baseline 1.7. So by day 14, we have removed all invasive lines and Foley's catheter also, and child was shifted to wards as fever spikes were also reduced. These were the trends of blood investigations in the ward, which we had done on weekly basis, where which showed hemoglobin and platelet counts had stabilized, and creatinine has reduced from 4.7 to 0.9 post 2 cycles of hemodialysis. So child was discharged after 24 days of hospital stay after physiotherapy. Now the patient is walking and on regular follow-up. So just to summarize our case, the importance of ventilation corrective steps cannot be undermined. We need to expect unexpected even in common clinical scenarios. Here in our case, the common clinical procedures such as open reduction, fixation of the fracture femur turned out to be near fatal episode for the child. And we need to find out whether there is any other safer alternatives to anesthetic agents like succinylcholine. Thank you.
Wonderful presentation, Doctor. Over to Stone, sir.
Yeah, great presentation, Siddharth. I think amazing cases from your stable. And this is not very common. I think all of us as intensive care, we go through that. Recently, also about 6 months back, we had another case with the scoliosis surgery, orthopedician doing. They had the same. What happened was they went into cardiac arrest. Then the child was on the ventilator for almost about 40 days or so. Then we had to intubate. We had to extubate the child. Now, but you see, last 4 5 months, the child is coming with a gait which is still not right, but also had rhabdomyolysis where we had to do a hemodialysis for this child because succinylcholine again was used on that patient, and we have had this. This is very common. It's very, occasionally, I'm not saying it's very common, it is occasionally, maybe once in 2 or 3 years, we do get this kind of thing from the anesthetist, where the differences from adult and the pediatric is that because from the OT, pediatric, we'll have to manage everything, whereas adult, basically, they manage with the adult physicians and adult anesthetists, they do that. So it's very nicely done, and very happy that this child could come out, because though initially was hypoxic a little bit and went into renal failure, rhabdomyolysis, and all those things, sepsis, all that, it could come out. Excellent management, and I think we should very careful that the succinylcholine. When the child comes to us, we should make sure that we see what anesthetist we have they have been given, because most often we don't hardly see what anesthesia agent they have given. So it's very important, because many of them go into this rhabdomyolysis after that, and many of them have severe renal failure, which needs real difficult treatment for them. So great. Thank you. Thank you to be here today. And excellent presentation, excellent management. I think Paramanand, you have mentored your juniors well, and congratulations for getting this child out of this such a difficult situation.
Thank you, sir. Thank you. Thank you so much, sir.
Thank you. Our chief guest, sir, Sulkifil, sir, your comment, sir.
Okay, thank you very much. It's a very interesting case. I mean, honestly, I am not an intensivist. I mean, I did a bit of pediatric intensive care before, but not that much. And this is the first time I've found out that succinylcholine causes rhabdomyolysis. And thank you very much for that education. And congratulations on the success of the management. Like I like to echo what Santosh has said. I mean, this is so rare, and then you've managed it so well, and the child has actually come out of it despite the AKI, despite all of that he's gone through, and he's got back his renal function back to normal, and hopefully that will continue and he won't have any long-term effects from it. Congratulations, and very well done. Thank you.
Thank you, Dr.
Thank you, sir. Thank you, sir.
By the way, Dr. Julkipil, I want to introduce Dr. Parmanand. He's our joint secretary for admin, and he takes care of everything. It's head of the department at this.
Is that a private hospital?
Yeah, it's a private hospital, sir.
Yeah.
Jupiter Hospital, Thane.
Thank you, Parmanand.
So
and it's a wonderful. This type of cases we wanted, and I had in mind that same type of cases actually. Today,
the intensivist who's working with me now is actually trained by Paramanand. Dr. Nikhil is with, he was working with Paramanand, actually, he was with me, one of them. So,
really great.
Thank you, sir. It was a great, this was a difficult case. When it came to in the casualty, I saw it was near fatal. There was no pulses, and I thought the baby could not make out. And just a minor error, that the cup pressure which was high and which was causing this, with just deflating it, we could see that the patient sensorium improved. And that went ahead and then saw that if there is definitely some hope of saving this kid. And then we went on aggressively and then saw that the quadriparesis was not improving. So what can be the cause? So that's the reason we saw that atlanodextral dislocation, all those things were not there. Whether some drug has caused this problem, and mostly the anesthetist. And the anesthetist which was in the private sector was the adult. That's the reason they use this choline. Now the pediatric anesthetist, they don't use it. And some of these kids have a genetic defect. and that leads to this rhabdomyolysis, renal shutdown, AKI, and all those things. So it was very heartening to see that child went home walking and without any neurological deficit. I was not sure how long she was hypoxic or she was hypotensive in the referring hospital. Maybe he was managed there for 12 hours. So at the end, when baby went neurologically normal, so we felt it's very happy about it. So thanks again, Singarole sir and Khalatkar sir and Nandam madam for giving us an opportunity to present our cases. Thank you, sir.
Thank you. Parmanand, you will get more and more opportunities. Don't worry. Really. It's a great day, great cases. Really. I think we really learn from our experience. Any Singarvelu sir, anything?
Ultimately, I think, as Dr. Ismail Professor asked, whether it was in the private sector, the vision and dream of all of us is that there should be uniformity and equality of healthcare, which is what I guess this educational things needs to impress, because that is the ultimate vision, that we are able to give the same care in across the border. That will be the vision of people from India and Malaysia and South Asian countries. With that, we have to move forward to disseminate this knowledge to. It is like, just because the child was in the right place at the right time with the right people, they are able to make it. It should be uniform. That's what we are saying. Like on Cancer Day today, 80% survival in high income and 20% in low income. Huge discrepancy.
Yeah. Thank you, Neelam. Great comments. So, vote of thanks. It's already done. Once again, I want to thank you, Dr. Santosh, Dr. Julkipet. Really, I hope you will come again and again to honor us. Really, thank you, and disseminate all this everything. If you want some slides, we can send it. Thank you.
Thank you. Thank you very much.
Thank you, sir.
Nice to see you, Zulfikar.
Thank you, sir.
Bye-bye.
Bye. Bye, Santosh.
Bye. Bye, Neelam. Thank you, Parmanand. Thank you, Singarvelu and team.
Thank you, sir.
Good. And
Thank you.
oh,
Bye bye, Dr. Vasan. Lovely vision. God bless you with more and more.
Yes.
400 500.
Thank you, sir. Thank you.
Ramanand, congratulations.
Thank you. Thank you, sir.
Sir, Singarvelu, sir, congratulations.
Thank you. Thank you. Thank you, sir. Thank you for all. For
Srinivasan, sir, good evening, sir. Good Srinivasan, sir.
It's a very grand.
We'll meet at 6 o'clock for the Tuesday clinic today, sir. Jalil bhai.
Oh, yes. Thank you. Thank you. Okay, sir. We will wind up. We are in time, exactly in time, and we will wind up this session.
Srinivasan, sir.